in terms of the conjunctival limbus and the cornea. So today we are going to talk about acute ocular surface disease, and I like to think of ocular surface disease as acute and chronic. And within the purview of acute ocular surface disease, the two main diseases that you would encounter as a cornea specialist are ocular surface burns and Stevens-Johnson syndrome or toxic epidermal necrolysis. Now, what I will try to do in this presentation is kind of show you what the similarities between these two conditions are and how the principle of management and also principle of clinical examination and then treatment within the purview of management is very similar between the two conditions, although they present very differently, and they are based on the same principle. So I'll try to kind of find common ground between these two conditions, and so that it's easy for you to fundamentally understand why we are doing what we are doing or what we are supposed to do. And so on the left side, you have these acute conditions, and on the right side, you have chronic conditions like dry eye disease and cicatrizing conjunctivitis and end-stage ocular disease, etc. Now, obviously, I'm sure that you understand that much of the chronic ocular surface disease can be a sequelae of the acute disease. So if one of the reasons or one of the what we are trying to do when we are treating acute ocular surface disease is to prevent or limit the sequelae as much as possible, or the sequelae in form of the chronic ocular surface disease. You can also look at ocular surface disease, and this is another way to look at it, in terms of acute on chronic, and chronic. So we talked about ocular surface burns and Stevens-Johnson syndrome and toxic epidermal necrolysis, or SJSTN as we like to call it, as the acute presentations. Now, why I call them acute is that in patients with SJS or ocular burns, the patients do not have any ocular surface disease before it starts all of a sudden. So that's why it's pure acute disease. So until the time that a person accidentally has some kind of a chemical or thermal agent or an explosive, hit his or her eyes, until that point in time, most of these patients are absolutely healthy. So it starts suddenly, all of a sudden. In the same way, most Stevens-Johnson syndrome patients are absolutely fine till the day that they suddenly develop these eruptions all over their body. Whereas in acute on chronic is where the patients present with acute disease, which may be very severe and sight-threatening, but it is usually over the background of something else that is going on as a chronic disease. For example, a common instance is what you all must have seen are shield ulcers in chronic allergic conjunctivitis, or patients presenting with corneal perforations or sterile melts in Sjogren syndrome, particularly secondary Sjogren syndrome due to rheumatoid arthritis, and also peripheral ulcerative keratitis, particularly Moulins ulcer. So the patients will keep coming, over varying periods of time with repeated ulceration and impending perforations and so on and so forth. And then you have the background chronic disease. Now, this background chronic ocular surface disease may be just dry eyes or maybe chronic conjunctivitis, either in the form of allergic conjunctivitis or cicatrizing conjunctivitis. It can be limbal stem cell deficiency because of any cause. And when all of these three present together, dry eye disease, chronic conjunctivitis, and limbal stem cell deficiency, that is what we refer to as end-stage ocular surface disease. So where you have the eyes are very dry, the surface is either conjunctivalized or dermalized, and the patient obviously has chronic disease. So all of these three together may have cicatricial changes also. So all of these three together would be what we refer to as end stage ocular surface disease. Okay, so in today's talk, we are going to focus on what is on your left side, which is ocular surface burns and Stevens-Johnson syndrome. And like I said, I will try to explain to you how these two conditions are similar, and how if you understand what is the basic principle in managing these conditions, then it will become very easy for you to understand why we are doing what we are doing. So when we are managing cases of ocular burns and of Stevens-Johnson syndrome or SJSTEN, we have to understand that the main purpose of managing these conditions. Now, obviously, I'm sure that all of you understand and appreciate the fact that these conditions are potentially blinding, that if not managed appropriately, the sequelae can be blind. The patient can lose the vision, and sometimes the patient can lose the vision in a way that it is completely reversible. So it is an emergency, there's no doubt about it. And what we are trying to do in the management of ocular burns and Stevens-Johnson syndrome is essentially to prevent completely or limit the chronic ocular surface disease, particularly limbal stem cell deficiency. Okay. And what happens in these conditions is that there are several changes or pathological events that are happening on the ocular surface that lead to these sequelae. And if you understand what these changes are, then you can understand what needs to be done to prevent each of these changes. So the most important event is damage to the epithelial stem cells. Now, when I say epithelial stem cells, I mean both the limbal epithelial stem cells, which are responsible for maintaining the surface of the cornea, and also conjunctival epithelial stem cells, which are responsible for maintaining the turnover of the epithelial cells on the conjunctiva. Unfortunately, unlike the fact that we know where the corneal epithelial stem cells reside, which is in the limbus, for the conjunctiva, we don't really know where the conjunctival stem cells are. There are different hypotheses that exist, but we are not very sure. Some people say it's in the fornices, some people have said it's at the lid margin, but at the transitional epithelium at the lid margin, but we are not 100% sure where they are. But wherever they are, we are trying to limit the damage to these epithelial stem cells, because the ocular surface, because it is essentially an epithelial surface and it's very delicate, it can get damaged quite easily. And when it gets damaged, the way that it will heal is from the regeneration through the proliferation of the epithelial cells from the stem cells, because epithelium has a very high turnover. So any epithelial surface anywhere in the body is maintained by stem cells, whether we know where those stem cells are, like in the limbus, or we don't know where those stem cells reside, like in the conjunctiva. The epithelium will regenerate from these stem cells. We know for a fact that these stem cells exist, although we don't always know exactly where they are. And it's the same for the skin. So you know that the ocular surface is a continuum, right? So you're looking at the skin from the lid margin to the conjunctiva, which drapes over the entire bulbar surface, and finally the limbus and conjunctiva, which covers the corneal surface. So all of this is a very delicate ecosystem and a very delicate balance that is maintained by the epithelial stem cells of different lineages, whether it is the skin or the conjunctiva or the cornea from the limbus. And whenever this epithelium is disrupted, the epithelial stem cells are responsible for producing new epithelial cells, which restore the epithelial surface. So the first thing that we would want to do, because both these conditions result in large epithelial defects over the ocular surface, whether it is in the conjunctiva or the lid margin or the cornea, is to limit the damage to the epithelial stem cells, so that if we can conserve or preserve these epithelial stem cells, then this epithelial defect can heal as fast as possible. The second thing that happens in both these conditions is damage to the conjunctival glands, including the ductules of the lacrimal gland, which are present in the lateral canthus, the lateral canthal area. So the ductules of the lacrimal gland, which are coming in from the palpebral lobe and which are opening in the lateral canthal area, plus the other accessory lacrimal glands which are distributed throughout the conjunctival surface, and of course the goblet cells which produce the mucus. So as we know that the tear film is produced, is composed of the aqueous component which comes from the lacrimal gland, the mucin which comes from the goblet cells, and the lipid which comes from the meibomian glands. Now, the most severe form of ocular surface disease occurs in aqueous deficiency dry eye, right? And therefore, these conjunctival glands and the lacrimal gland, if they are damaged, or the conjunctiva around the lacrimal gland ductules, if they are damaged, along with the conjunctival accessory lacrimal glands and the goblet cells, then that would result in a deficient and unstable tear film. So the damage to the conjunctival glands needs to be limited. The third thing that happens is inflammation on the surface. Now, when you have a lot of outpouring of inflammatory cells and cytokines on the ocular surface, then that leads to, that leads to a kind of a vicious cycle that sets in, which brings in a lot of vessels, which brings in granulation tissue and ultimately scarring, etc., in the process of healing. And sometimes this process can go out of control and it can become very severe. And then because of all of this, you can have delayed reepithelization. So if the epithelial stem cells are damaged, the conjunctival glands are damaged, the surface inflammation is persistent, it does not subside, then all of this can lead to the epithelialization getting delayed. And when the epithelialization gets delayed, then you have fibrosis. You have fibrosis in the conjunctiva, you have scarring in the corneal stroma, and all of this ultimately will lead to what we are trying to prevent, which is the chronic ocular surface disease or limbal stem cell deficiency. Now, with regards to the damage to the epithelial stem cells, that manifests as epithelial defects on the surface, which are healing slowly or not healing at all. Damage to the conjunctival glands and the periglandular tissue around the lacrimal glands results basically in a deficient and an unstable tear film. Inflammation, which is persistent on the surface, leads to neovascularization, angiogenesis, and delayed reepithelization results in persistent epithelial defects. And fibrosis, like I said, manifests as scarring and symblepharon, corneal scarring and symblepharon or foveal shortening and other changes on the conjunctival surface. So these changes that you see as clinical signs, epithelial defects, is because of stem cell deficiency or stem cell dysfunction. You see tear film instability because of periglandular damage around the lacrimal gland or damage to the conjunctival accessory lacrimal glands or the goblet cells. You see neovascularization because of persistent inflammation. And you see persistent epithelial defects because of a delayed epithelialization. All of these coming together and then delaying the epithelialization process. And ultimately, all of this again leads to scarring and symblepharon. So epithelial defects need to be prevented, number one, by removing the inciting agent. So whatever is causing the epithelial defect in the first place. So we know that in ocular burns, it is the chemical by its nature that damages the epithelium, the epithelial barrier, leads to cell death and causes epithelial defects. So that inciting agent, which is causing this epithelial damage, needs to be removed. And we know that in SJS/TN, that inciting agent often is a pharmacological agent or drug or an infection. So that needs to be taken care of. To restore the tear film instability or to mitigate it, we need to give lubrication. To prevent these vicious cycle of inflammation, which leads to neovascularization and fibrosis, we need to use corticosteroids. For preventing epithelial defects to become persistent, we need to promote epithelialization various ways. And all of you know what the ways of promoting epithelialization are, whether it is the use of amniotic membranes or bandage contact lenses or tarsorrhaphy or autologous serum, etc. And then finally, to prevent the scarring in symblepharon, if you do all of these things right, then eventually you will be able to prevent the scarring in symblepharon. And if you have prevented the scarring in symblepharon, then you will obviously be able to mitigate or limit the amount of ocular surface damage or limbal stem cell deficiency that is going to occur. So this slide is very fundamental to understanding what essentially we are trying to do in the management of ocular burns and SGST. If you have any doubts, please feel free to ask. Now, this is the classification system that has been proposed by Harminder Dua for grading of chemical burns, but I think I find it extremely useful for any kind of acute ocular surface disease, whether it is chemical burns or whether it is acute Steven-Johnson syndrome, because it is a way of assessing what is the extent of damage to the system. So he's graded that based on the percentage of limbal involvement and conjunctival involvement. And I hope all of you are familiar with the grading system. I'll show that to you also in a while. I've just depicted it pictorially over here in this schematic. So grade 1 is when it is limited to the cornea. Grade 1 is when it's straddling the limbus, but the amount of limbal affliction or conjunctival defect is minimal. Grade 3 it is a little bit more, and from grade 4, 5, and 6, it becomes just more and more and more. So you can see here that there is some residual limbus from grade 5 to grade 1 to even grade 5. Okay, but in grade 6, there is no limbus left and there's no bulbar conjunctiva even left. The entire surface is taking a stain. So that's the more severe form. So till grade 5, you have some hope of the ocular surface reepithelizing from the limbus that is remaining or that is still intact, even if it is a very small amount, just 1 clock hour or even half clock hour or 1.5 clock hours. So what this slide tells you is that the healing reserve is inversely proportional to the size of the surface defect. So the larger the defect on the surface, the lesser is the reserve. So you have lesser intact cells to compensate for the damage that has already occurred on the surface. So fluorescent staining and just examination of the surface in cobalt blue light using the technique that I described in the earlier class, that you have to don't just depend on blinking for spreading the tear film, because tear film itself is abnormal, the lids themselves are abnormal. But take a fluorescent strip, wet it, paint it over the ocular surface nicely, ask the patient then to blink, and you will get a nice stain that you will otherwise miss in many cases of burns because you have just put the dye in the cul-de-sac. And once that staining happens, then assess the extent, how much of the limbus is affected and how much of the conjunctiva is affected. And then the larger the amount of limbal defect and the larger the amount of conjunctival defect, it tells you that the lesser is the healing reserve. It does not mean that it will heal or not heal. It just means that the reserve is less, and therefore you have to do even more. You have to put in more effort, lesser the reserve, to make sure that that healing happens without too much of sequelae. So obviously you expect in grade 1, grade 2, grade 3 that with medical therapy, because the reserve is quite large, that these epithelial defects will resolve quickly and epithelialization will be fast and sequelae will be minimal. Whereas from grade 4 onwards, particularly grade 5 and 6, there you know right at the onset that the reserve is so little that this needs to be addressed surgically. There is very little that you can achieve medically, or the risk of developing sequelae or other complications is very high if you go with medical therapy alone. So That's obvious from this photograph. What is also obvious from these images are that the lesser the reserve, the the more prolonged the healing period is going to be. So this is also something that you should keep in mind. So the greater the defect, the longer it is going to take for that epithelial defect to heal, irrespective of the cause, whether it is HS or whether it is burns. Now, in chemical burns, I like to divide the management into, of course, clinical examination, etc. We already discussed in the last class, and I just talked about it. So any patient coming in with acute burns, you first make the patient comfortable. You put a little bit of topical anesthetic in the eye. You clean the surrounding area. Sometimes there's a lot of eschar, there are scabs, and you need to clean all of that. Clean the eyelids nicely, very gently. Okay, and then examine the eye. And if the patient is just coming from, uh, is just reporting after the burn has taken place, and within a few hours or within a few days, and if no acute management has been done, and even if a little bit of acute management is, you're not sure what has been done, it is very important that you understand what are the non-negotiables. Non-negotiables means this has to be done. So you have to remove the chemical and all its residue from the eye. And the way to do it is to irrigate the eye. The best way to do it is to irrigate the eye. Now, there are certain special solutions that are there for irrigation of the eye, but any buffered solution will do. Okay. So if you have balanced cell solution, great. We usually will not have that in the emergency, but we'll have ringer lactate, and that is fine. That's a good compromise. So use ringer lactate. If you don't have ringer lactate, you can even use normal saline, although it's not optimal. Even if you don't have normal saline, if you are in the secondary center for some reason or somewhere else, you can even use tap water. That's better than nothing. But obviously, you would like to use a buffered solution so that the pH can be normalized. So the you know main goal of irrigation is to clean the eye, remove the chemical, and also normalize the pH. So there will be usually, certain kind of burns like firecrackers or chemicals like tuna, because these are semi-solid material. There is a lot of debris. They collect, and if you swiftly wash it, then they come out. Otherwise, they can get trapped in the tissue. Once the conjunctiva gets deepithelized, there's a lot of loose tenons underneath, and all of this stuff kind of gets caught up in that loose stuff as it gets hydrated by the tears, and then it becomes very difficult to remove. So as early as possible, irrigate for the end point obviously is for the pH to be normalized. And in the emergency nowadays, you do have the pH strips that are available. If they are not available, just let somebody know, and they will be made available. I know that uh, when Swapna had joined, she had made sure that in 2018 or 19 that pH tips were available in the emergency room. If they're not there now, just let somebody know and we will order them and have them in the emergency room. So that is the end point of irrigation. Typically, it will take you 2 bottles of ringer lactate to achieve that, even more depending on, um, but rule of thumb is about 2 bottles. Another non-negotiable is the use of topical steroids. It has to be used. Topical steroids are very, very important because uh, otherwise the eye will go into this kind of downhill spiral of a vicious cycle of inflammation. And like we just discussed in the previous slide, vicious cycle of inflammation means a lot of vascularization and scarring. The other important thing, which I think is undervalued or understated, is to prevent exposure. I think this is a very, very important uh, step in the management and prevent to ensure proper healing, rapid healing, and to prevent sequelae, is to prevent exposure. And these are the four mainstays of your treatment. So absolute non-negotiable. You cannot think of anything else before doing these things. So clean the eye, examine it, remove the chemical, irrigate, 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 irrigate. If you have a pH strip, irrigate till the pH is normal. If you do not have a pH strip, just use a couple of bottles of ringer lactate, use a visco cannula, put a speculum in the eye, um, double livert the eyelids, wash everything, wash clean. Then start the patient on topical steroids and prevent exposure. The easiest way of preventing exposure is by putting a soft bandage contact lens, and that will usually suffice. If there is a lot of chemosis, etc., then it might be difficult. So you wait for the chemosis to resolve with the steroids and then put a banded contact lens. The other way to prevent exposure is by doing a tarsorrhaphy. You can just do a temporary tarsorrhaphy. You don't have to do a permanent tarsorrhaphy just in the beginning. But if you're unable to put a contact lens and if you see a very large defect on the surface, you might even do a temporary tarsorrhaphy. It is unclear whether oral or topical vitamin C helps. There is a certain amount of evidence in literature which says that it helps because vitamin C is a cofactor in collagen synthesis, and one of the things that you're trying to prevent is corneal stromal melting, which is essentially collagen. The same for doxycycline or other tetracyclines and citrates. And then the role of intense lubrication after irrigation has been done is also uncertain. But of all of these things, lubrication is easy, it is inexpensive, and therefore I don't think that there is any harm. But you have to understand that this is not the mainstay of treatment. So in terms of topical medications, you have to understand that topical steroids, particularly prednisolone acetate, is the mainstay of treatment. If you are giving the patient oral or topical vitamin C, doxycycline, and lubricant drops, that's fine, but that should not be your mainstay of treatment. Okay. And similarly, lubrication can also be enhanced by using autologous serum and cord serum. There are some randomized control trials which have shown the benefit of autologous serum, cord serum over normal lubrication. But like I said, the lubrication itself, whether it is really required, we don't really know, but it doesn't harm to give it. So it's unclear, but you'd probably end up giving this anyway. And what are the indications for surgical intervention, particularly amniotic membrane grafting in chemical burns? Again, there is no consensus on this, but what is recommended and what we generally tend to follow here is that if you have a patient who's presenting with residual chemical, that irrigation has happened, but there's a lot of chemical that is stuck onto the eye, and you can't really remove it. Even after irrigation, it has not really, you've not been successful in removing it. It's all stuck with the tenons, etc. It needs to be surgically removed. Then, of course, while you're doing it, you might as well do amniotic membrane grafting. So if there is residual chemical with tissue necrosis which needs surgical debridement, please go ahead and you're taking the patient up for surgery anyways. So please go ahead and do amniotic membrane grafting as well. If you have a very large defect, like I said, grade 5, grade 6 defect, then our threshold for doing amniotic membrane grafting is lower in those cases. It is not that every grade 5, grade 6 burn will require amniotic membrane grafting, but there your threshold is lower. I would recommend that a good irrigation and medical therapy should be started, and then patient should be reviewed. But if it's a child who would need examination under anesthesia anyway, this is the indication that you will use for doing an amniotic membrane grafting. So if the child is not cooperative, you're not sure how much chemical you're going to take the child under anesthesia to see the amount of damage on the ocular surface, then instead of posting the child for EUA in CCCUR, you might as well post the child in the main OR with a plan of amniotic membrane grafting and tarsorrhaphy based on what you see in the OR. Similarly, if you have started the patient on medical therapy where you are able to monitor the response and you see that there's poor response means you've treated the patient for a week or so, the defect has not become smaller by more than 50%. It's the cornea is still exposed. You don't want to keep putting steroids in the eye without covering the cornea for more than 7 to 10 days because the chances of sterile ulceration increase. So that you go in and do an amniotic membrane grafting at that time. Or if the patient presents, maybe not in an acute burn, but if the patient presents maybe a week or 10 days after the burn with already a melt that has started, you would definitely not wait and go for an amniotic membrane grafting in that case. Now, This is a 45-year-old male, injury to both eyes with acetone-based chemical. What you see in the right eye and the left eye. I just want somebody to describe, one of the fellows. And my questions are, based on what you see, what would be your primary line of management based on what we've discussed so far, whether it will be medical or surgical, whether it will be different for each eye. What do you think are the factors here that influence the outcome? And how would you explain the visual prognosis to the patient? Anyone?
Good morning, Dr. Sir.
Good morning. Go
In
ahead.
the right eye, cobalt blue filter direct illumination shows up to 60 to 70% of epithelial involvement and around 10 to
So
20%
what
of
you're
conjunctival.
worried about here, Preetham, is not how much of the corneal epithelium is deepithelized. So that's the point I was trying to make earlier. What you're worried about is how much of the limbus is deepithelized. So what percentage of the corneal epithelium is gone doesn't matter. How
Yes.
much of the limbus is remaining is what matters.
Okay.
So here you
So
see a limbal defect of about 3
2
clock
to 3
hours.
kilometers. Yeah.
Yeah, 2 to 3 clock hours, and a conjunctival defect, which is what, 15-20% in the right
Mm.
eye of the entire bulbar surface. So this would be a grade 2, or maybe, between a grade 2 and a grade 3 burn, right?
Yes.
And in the left eye,
Uh, stay around.
so in the left eye, if you
Yes,
see the staining, you're
up
staining
to
on the
9
tarsal
clock hours.
conjunctiva also, almost the
Yeah.
entire bulbar surface is gone, and entire 360-degree limbus is gone. Hello?
Yes, yes, doctor.
Bolo?
So 12 clock hours involvement and close to 90 to 90%, 80 to 90%. Grade 5, grade 3.
So this is a grade 6, according to Dua.
Yes.
Okay, we're not looking at Roper Hall, we're looking at Dua. So what will be your primary line of management in this case? Will it be different for both eyes, or will it be the same for both eyes?
So in an acute burn, like we have discussed, non-negotiable terms. First, we'll remove the chemical, irrigation to be done, and topical steroids to be started. And we can try prevent exposure in this cases by placing a BCL to start.
Okay, so another thing that's important over here is that when you start the patient on medical therapy, it also depends on where the patient is from. So in local patients, you can start the patients on medical therapy. It's always advisable that you start the patient medical therapy, call the patient back in 2 to 3 days, or let's say if both eyes had the presentation that is there in the right eye, then you can call the patient after a week. If both eyes had a presentation that is there in the left eye or similar to that, you would call the patient more frequently, or sooner, not more frequently necessary, but sooner, and reassess. But let's say if this patient was presenting from very far, then you might have a lower threshold for a surgical intervention in the left eye, because you are not sure after starting medical therapy whether the patient will come back for follow-up or not. So that's an additional kind of confounder or consideration that we have to keep in mind in our context. It may not necessarily be a medical indication, but it's a logistical indication that if I'm starting the patient on hourly steroids and I don't know if the patient is going to come back to me after a week, I might as well do an AMG and tarsorrhaphy in the left eye before I send the patient, right?
Yes.
Okay, so what are the factors that influence the outcome? Like, how would you prognosticate the case? What would you tell the patient are the chances of the patient recovering in the right eye versus the left eye?
So the chances for the right eye are much better. The prognosis of the right eye is better. Left eye can expect the prognosis to be uh, first, and we'll ask the patient to follow up closely, and over time we can might need multiple procedures in the future.
Okay, so your expectation is that the right eye will epithelialize very well, and the left eye, what do you expect will be the clinical sequelae that will happen in the left eye in this
So
case?
epithelialization might not be possible in these cases, and so it might lead to the next spectrum, like we discussed. There can be a glandular dysfunction or persistent inflammation and delayed reepithelialization in these cases.
So what will that manifest as eventually? Let's say you did everything in this case. You did AMG, tarso, gave steroids, and so on.
We can still have an persistent epithelial defect, or on ideal situation, we can have a conjunctivalized one with
So
this
limbal stem
steroid
cell
evaluation.
deficiency in this
Yes,
case
yes,
is what you expect at this presentation, correct? When you're seeing the
yes,
patient now.
yes.
Okay. So this is what the patient presented with. I'm just showing you the same patient's photographs with the fluorescent staining in normal light and under the cobalt blue filter. Now, in this patient, we gave medical therapy in both eyes. This patient was local from Hyderabad, and this patient came to me almost 8, 9 years ago in 2013, I think. And in the right eye, as expected, he did very well, and the right eye, resolved. But the left eye also did fantastically well. It took a little while longer, and the epithelial defect resolved slowly. Like you can see, this is the presentation at about 10 days after, and this is about 1 month. You can see that the epithelial defect has just healed. There is still some stromal edema, but the final photograph, which is at the bottom, is at 6 weeks, and by 6 weeks both of the corneas had completely resolved, and it looks like the patient is going to have good vision in both eyes, and the prognosis is not as bad in the left eye as we expected, right?
Yes.
So what did we miss?
So I think we cannot estimate the limbal ischemia which comes in these cases, and in acute, it is even more difficult to assess limbal ischemia to
Correct.
start.
So the factor that we did not take into account, or we could not, or did not look at clinically, or we were not paying attention to, or we didn't discuss, is limbal ischemia. Now, limbal ischemia is the single most important factor which determines the prognosis, having done all the non-negotiables and all the other things that you should have done when the patient presents to you. This is something that is not under your control, and the greater the amount of ischemia and the deeper the ischemia, the worse is the prognosis. So the actual the main limitation, and I'm giving you this case just to illustrate, I mean, I'm showing you this case just to illustrate the main limitation of uh, Dua's classification of burns is that it does not take into consideration limbal ischemia. And it probably does not take into consideration limbal ischemia because it's difficult to gauge clinically. But unless you have an idea, it's very difficult to prognosticate, because even a grade 6 DUA, like I showed you in the fluorescent staining, can resolve with very minimal sequelae. This patient does have some peripheral conjunct. I've been following this patient up for the last, like I said, 8, 9 years. I've recently done cataract surgeries for him in both eyes. He has just a peripheral frill of very thin conjunctival tissue inferiorly, but otherwise his central cornea is absolutely fine. His superior limbus is absolutely fine, and he still has a good ocular surface. He hardly needs to use lubricants and so on. So this is just to illustrate the fact that limbal ischemia is very important in the prognosis, and just going by the epithelial defect will give you some idea, but you will miss those really bad cases where there is limbal ischemia, and you will overstate the case. And this is the reason why I'm emphasizing the point that don't jump for surgery unless you have the conditions which I explained initially, that you have to surgically remove the chemical, or it's a child, or it's already presenting with keratolysis, or there's patient is not going to come for follow-up. Otherwise, don't jump, because often there is not enough ischemia. The epithelium will heal, and often, even if there is ischemia to start with, the ischemia recovers very quickly with the use of steroids. So it is only kind of vasospasm that goes away once you use topical steroids intensively, and you can have very good recovery without any surgery at all. And therefore, the grading of chemical burns per se, it has these following limitations, and I just wanted to show you this case to illustrate that. I'll just show a few more cases before I go on to some more salient important things. This is a case which presented with small, you can see epithelial defects on the cornea. So this would be Dua's grade 1. But what you don't see in this, I mean, no limbus is affected, right? And so you'd say, okay, I will start maybe just give the patient lubricants and this epithelial defect will heal. But it will not, because what the patient has on the corneal surface is a plaque of the chemical. So the chemical is actually deposited as a plaque on the corneal surface. Even if you pour steroids on this cornea, that epithelium can't grow over the plaque. So it has to be surgically debrided. So this is the reverse, where you have a very small defect and you think that, okay, according to the worst classification, this is very small. This is, grade 1. This should resolve very quickly. I don't have to worry about this, maybe not even put BCL. But this is a case where the epithelium will struggle to resolve, will bring in a lot of vascularization and scarring because it will take so much time because there's a plaque. So that plaque needs to be debrided. So we did a debridement of the plaque and then the epithelium resolved very well. So again, another exception to that rule. This is a case with an hot oil falling in the eye. So you can see where the oil has spilled on both the inferior cornea and on the conjunctiva. Again, it looks very bad. But if you persist with your medical therapy and you keep assessing the patient as to how is responding, you can see that at 1 week, only a small defect remains in the left eye. And then finally at 1 month, the defects are completely gone. Some amount of corneal scarring remains. The patient still has that, but overall the surface has completely healed. So in Roper Hall, it takes ischemia into account. Duas does not. We do not have an universally accepted classification system. We know that limbal ischemia is most important, and clinical assessment of limbal ischemia is not reliable. We did a very interesting study in one of our workshops 3 or 4 years ago, where we had a whole range of people, starting from optometrists to ophthalmology residents to ophthalmology fellows, cornea specialists, and ocular surface specialists, and we showed them the same set of photographs with burns, and we said, does this eye have limbal ischemia? Yes or no? And if it has, how many clock hours of ischemia are there? And where is the ischemia? Which clock hour to which clock hour? And the reliability across the spectrum was very poor. The agreement was only around max around 30 to 40%, and that also the best agreement was amongst the ocular surface specialists. Otherwise, among residents or fellows or even cornea fellows, there was hardly any agreement between what they saw as ischemia and where they saw it. So one of the main reasons why ischemia is so difficult to clinically interpret is because of the congestion and the subconjunctival hemorrhaging that accompanies it. So because there is bleeding and because there is congestion, it kind of sometimes masks, the eye looks red. So you think there is no ischemia. Of course, in those cases where the perilimbal tissue is absolutely white and you can see the sclera, even the tenons is necrosed off. Sure, everybody can recognize or identify ischemia in those cases. But we are not talking about those. We are talking about more subtle cases where you should be able to pick out ischemia, like both these cases that I'm showing. In the lower case, you can see obviously that there's ischemia in this area over here. That is easy. But this patient also has ischemia over here, which is not so easy to pick out because you have a lot of congestion and you can see there's some amount of subconjunctival hemorrhage over there. In this patient, there's almost in the figure on top, there's almost 360-degree ischemia. It doesn't look like from the photograph. So we need a more reliable way. We have been working with the OCT angiography for a while. So you can see the photographs on your left show what a normal limbus and a normal nimbal vascular arcade looks like. The photographs on the right are photographs of patients with acute burns, where you can see that there is ischemia and only some of the major vessels have blood flowing through them. So the good thing about OCT angiographies is that it only maps those vessels which have blood flowing through them, not the empty vessels, not the vessels which are closed off because of vasospasm, etc. So that's what you see here, ischemia both in the figure on top and in the bottom. In the bottom, you can see that the limbal arcades to some extent are preserved, but otherwise it is damaged over there. So these arcades over here are preserved, but you can see that the perilimbal vessels, these are gone. So just to show you a few examples of recovery, these are three, um, you have the um, diffuse illumination photographs, fluorescent stain, infrared imaging, and OCT angio of the same eye, same area, which shows an epithelial defect at presentation. Um, and you see complete ischemia over here. There are no vessels. But after starting treatment, you see that there are congested vessels. The vessels have reperfused on day 7, and there is almost completely normal vasculature that has been restored by day 14. So the presence of limbal ischemia itself at presentation does not, again, just like the presence of a very large epithelial defect at presentation itself, it warns you, it tells you that you need to monitor this eye carefully, but it does not necessarily mean that the patient will have a poor prognosis or the patient will have need surgical intervention. So that is why I am again reiterating that observe these cases for some time. Do not rush for surgery unless those factors which I mentioned before they exist. Okay, because like you see in this case, severe burn, a lot of ischemia even on angiography, but good clinical response with surge with almost complete normalization. Epithelial defect is gone, vessels are back in only 2 weeks. Here is another example where you have complete ischemia. You can see here on presentation. Then there is reperfusion with vasodilation at around 7 days, and then that settles down by 14. And if you follow these patients up, then you can see that there is normalization of the vascular pattern without any LSCD formation. Another example here of complete limbal ischemia, you can see here, and then you can see partial reperfusion at day 3 with congestion, gets a little bit better with the congestion going away by day 14, maybe some amount of neovascularization by day 21, and you have more vascular perilimbal architecture by day 28. Sure, some of these cases may develop by some sequelae, but it is not dead necrotic tissue as some people would like to call it. Ischemia does not necessarily mean that it is already dead. It can be perfused. The other thing that we have seen definitely is that there is a better correlation between the amount of ischemia and the response to therapy than just the epithelial defect. So in both these cases on above and below, both are cases of grade 6 DUA. The one on top, you can see that there are at least 3 quadrants in which you can see some vessels. The one on the bottom, you can see that there are almost no vessels except for this isolated area, so around only 10 to 15% in the eye at the bottom. And you can see that the eye on top with medical therapy has completely resolved by day 28. The epithelial defect has progressively become smaller. Whereas in the eye at the bottom, even at 4 weeks, you have a epithelial defect remaining and the patient developing possibly limbal stem cell deficiency. And that the prognosis, therefore, overall in the eye, in the previous photographs, I just showed you one quadrant, depends on what is the total amount of ischemia that is there in the eye. This is another case where you start off with ischemia in the temporal quadrant over here, and this continues, while the rest of it resolves, you have this small amount of ischemia that persists at 6 weeks, and it is in the same area that the patient develops a pseudopterygium. So you can see that the same area has healed with pseudopterygium formation because of the persistent ischemia in that area, because it's a deeper burn. It's gone down to the episcleral vessels and burned it. The other thing that I wanted to mention, particularly for those fellows who are joining in, that when I say do AMT, it means in burns or whether it is in SJS, it means that you do AMT with the minimum amount of surgical trauma. So if the cornea is deepithelized, most of these cases will be where there's a large epithelial defect over the cornea and over the entire ocular surface. So in these cases, you are trying to address that, and there will usually be some amount of a conjunctival epithelial defect also. Um, so what you're trying to do here is put the AMT all over the corneal surface, okay, and then you will put the 10-0 nylon running sutures in the corneal periphery, and keep a long end over here, or you can keep a short end and then bury it. You can just pull it and bury it, and then you will put another either interrupted sutures, like another row of interrupted sutures, or another continuous suture through the epithelial tissue with a long thread, or again buried over here. So you are gluing this membrane as well, but you have to understand that as the epithelium starts to grow underneath it, that AMG will become loose very fast, and then it can come off. There is no problem with reapplying the amniotic membrane, which you can always do. But because we don't have something like Procera, which can be inserted in the, under slit line guidance in the clinic, therefore you have to take the patient to surgery, and therefore putting nylon sutures is better because it ensures that the amniotic membrane will stay on for as long as possible. But when the amniotic membrane dissolves, if there is still another defect, you might still want to do, you can repeat it, and it is usually we accompany it with a paramedian tarsorrhaphy so that we limit the exposure. So this is a case with a severe tuna burn. You can see that on lead eversion, there was still a lot of tuna done under, examination anesthesia. All of this was removed, and AMG was done here. An AMG was also put on the tarsal surface, and this patient then resolved very well with a total limbal stem cell deficiency with symblepharon. You have to understand that this is a good outcome in this case because we can then restore the surface from the other eye. So in some cases where the injury is very severe, limbal stem cell deficiency or symblepharon formation is a natural sequelae which cannot be prevented, but we can only limit what happens. The other things that are important before I quickly touch upon SJS, and the reason that I'm mostly talking about burns and not talking so much about acute SJS is because you will hardly see acute SJS during your tenure here. And chemical burns is what you'll see most, but the principles are very similar. So in chemical burns, also remember that each chemical acts very differently and penetrates variably. So you have to keep that in mind. It's not, it's very different for each individual case. So you should give each individual case the attention that it deserves. The concentration, pH, and duration of contact influence the final outcome because that determines how much ischemia these patients develop. Do keep an eye on intraocular pressure on follow-up. A lot of these patients have hypotony. A lot of these patients can also have elevated intraocular pressure, and that requires management. Look for signs of iris. Once the cornea starts to clear, look for signs of iris atrophy, a fixed pupil, or sometimes ectropy and UVA, or peripheral antiacynic, which are all surrogates of angle damage and of deeper penetration of the chemical, or even a complicated cataract. Some cases have endothelial damage, and therefore the OCT lines scan becomes very useful in those cases to see thickening. And then those cases you can, the cornea may not heal because it is edematous. And so there you need to do keep the tarsorrhaphy on for longer till conjunctivalizes. Severe ischemia can also present with hypopion and also hypotension. And in these kind of severe cases, sequelae like symblepharon may take several months to manifest completely. So this has two implications. One is whenever possible, where the risk of amblyopia is not there, wait as long as possible before doing reconstructive surgery. A lot of people will say, sir, when do we do SLET after acute burn? So you wait as long as possible. So there's no hard and fast rule that it has to be done after 1 month or 6 weeks or 3 months or 6 months. You wait as long as possible. Of course, our hands are tied and our kind of hands are forced when for very young children where there's a risk of amblyopia, then we go in early. And like I said, AMG in the acute phase may need to be repeated several times. Okay. Now, just like for in chronic ocular surface disease, we have a few things in our armamentarium which are very important if we are going to tackle a chronic ocular surface disease like systemic immunosuppression, scleral contact lenses, simple limbal epithelial transplantation, mucous membrane grafting, and keratoprosthesis. In managing of acute ocular surface disease, we are dependent on topical steroids, autologous serum, bandage contact lenses, tarsorrhaphy, amniotic membrane transplantation, tenon patch grafting for managing melts and perforations, and tectonic keratoplasty or patch grafting for larger perforations. So these are all the surgical procedures that you should be familiar with by the time you finish your fellowship, or if you are going to be managing ocular surface disease. So the procedures for managing acute disease are on your left, and the procedures for managing chronic disease are to your right. Now, I'll just leave you with this one line on SJS, and maybe, we will talk about acute management in more detail in a separate class because it's mostly surgical. But just like we talked about the principles of protecting the stem cells, limiting the inflammation, hastening the epithelial healing, preserving the conjunctival glands, preventing PEDs from forming and scarring and vascularization. Those same principles as burns. Here, we stop the inciting drug if that can be identified. A good cleaning examination needs to be done. Topical steroids need to be given, okay, even if the patient is in the ICU. Exposure has to be prevented. One of the big problems of SJS patients, because they are often unconscious or semi-conscious in the ICU, is that the eyes remain open. So you have to make sure you tell the nurse that you or the attendant that they should always put some lubricant or some ointment, if there is lag of thalamus, or you can even do just a bedside suture tarsorrhaphy to prevent that exposure. We do not know for sure what is the role of systemic steroids or cyclophosphamide or cyclosporine or IVIG in the management of acute SJS. There is a lot of literature on it, but there is no clear consensus on it. And we do know that for the ocular sequelae, amniotic membrane grafting within 72 hours of onset of disease is very, very helpful. And again, for large defects and poor response, if you are where you are not able to follow up the patient very frequently, amniotic membrane grafting using the same principles is important. These are just a couple of cases where this is almost looks like a burn, but it's actually a case of SJS, where after cleaning and everything, you find that the ocular surface is not so bad. And then we gave this patient medical therapy. Similarly, another case where again, the eyes look very bad, but after cleaning, you can see that the ocular surface is not looking so bad. The amniotic membrane in these cases can be inserted using these loops that can be made from IV tubing. And you can read about it. There's a lot of literature on how this can be done. There are different techniques also. You can also use tissue adhesive to secure the amniotic membrane to the eyelid margin and then push the ring in to, instead of using sutures, you can use tissue adhesive and use the ring to keep the amniotic membrane in place. These are methods that are done. Why are we doing this in SJS when we did not do this in burn? Because in burns, you have the patient and otherwise you can take the patient to OR and operate. In SJS patients, these are patients who are still fighting for their life, who are admitted in intensive care units. So you can't really do very extensive surgery, particularly surgery that bleeds. So you have to find a way in which you can do this without causing too much trauma, without causing too much pain. And that's why these modalities are used. And this is the same patient after the amniotic membrane, etc. So just to conclude, these are acute ocular emergencies, burns and SJS. Make sure that you always do a good, complete examination. Prevention of corneal melting and scarring and promoting epithelialization is your main goal, as we discussed. And the primary and most important step is always for chemical burns, remove the chemical, irrigate, clean the eye. In SJS, the most important thing, if you know which drug, then stop it. And then medical management must include topical steroids. Amniotic membrane is your go-to surgery, but remember that it is not a panacea that you'll throw the amniotic membrane in every case. It is only useful in very severe cases and certain indications which we discussed. Do not underestimate the role of tarsorrhaphy. Like I said, preventing exposure is one of the most common reasons why burns and SJS are badly managed is that exposure is not taken care of. And then all of the other things that I talked about, especially about comorbidities. Okay, so I hope this class has been helpful. I'll close here now. And then if you have any questions, again, last time I must thank all of you who wrote to me with your doubts. And again, this time I encourage you to write to me for your doubts. You can WhatsApp me also if you have my number, or if you see me somewhere, please feel free to ask any questions that you have on the topic. The next class, I think, is on next Tuesday, and it's on chronic ocular surface disease. And I think the next one is on cicatricial conjunctivitis. All right. Thank you so much.